We have been using DCB for last around 2 years, and at my center, mostly we use sirolimus DCBs. Around 80% of cases, we have been using sirolimus DCBs. For last 1 year, I've been doing in de novo lesions. Earlier, it was with only ISRs. So I would share a few of the cases. So this is case one. This is PDA, 90% lesion. You can see medium-sized vessels. So basically, the definition of small size as per UK bifurcation group is less than 3, but Indians usually they have less than 3 or 3 millimeter vessels. So you can see the lesion in PDA, 90%. We prepared it well, first with NC, then cutting balloon. The slides are not moving. Then we deployed or applied Magic Touch 2.535, and you can see the final result. Not much of recoil. This is another case too, 39 years old female with ACS. So thought of not giving her a stent at this age, and we thought of doing a DEB to OM. First we prepared the lesion very well with cutting balloon, and then you can see with Magic Touch 2.525, see the very less recoil and very good result, and she is doing well. This is another case of LED diagonal bifurcation. This is basically a type of dual LED. You can see some calcium also, and in every case we try to do IVUS because we have to size the vessel, size the balloon with the vessel exactly. And then I thought of doing 2 DCBs. This is one DCB 2.535 in LED, the another Magic Touch 2.510 in diagonal, and here is the final result. Because the size was distally, both the LEDs were around 2.5, so we thought of doing this case with DCB. So this is the final result, and it appears very, very well modified lesion. It is there is no much of recoil. This is LED D1 bifurcation, case 3. You can see here. So because diagonal is a good size vessel, I didn't want to lose this vessel. Neither I didn't wanted to put a metal jacket here because the risk of restenosis, because the size was around 2.5. We put a stent here, and then we did this cutting balloon and DCB, and this is the final result. The patient came to me after 3 months, and then we did a check, and he agreed for a check angio. Most of these patients, they don't agree for check angio. We have most of clinical follow-ups, not angiographic follow-ups. And you can see the positively remodeled diagonal after 6 months. And he was doing very well clinically also. And this is a case of RCA, PDA stenosis. You can see a tight lesion and very large PDA, PLV. And we did a DCB in this case. Plaque modification with cutting balloon is must, so that there is no much of dissection and recoil. And then Magic Touch 2.530 applied here for 60 seconds, and you can see the beautiful result, no recoil. This was actually a 40 years old medico who came to me with LED ACS with high bleeding risk because he was a case of cirrhosis and portal hypertension. He had variceal bleed 2 months back, so I gave him an option of going with DCB. So he agreed to that because we wanted to stop those blood dual antiplatelets. I discharged this patient only on one single antiplatelet, clopidogrel, and you can see the lesion modification with cutting balloon, and the lesion gave it through the cutting balloon. Then we applied DEB Magic Touch 3 by 15 millimeters after doing an imaging study, and you can see the beautiful result, and patient is doing very well after 6 months even. This is distal RCA lesion, diffuse distal RCA lesion, and at one point appears tight lesion. Then we prepared the lesion. This was done with paclitaxel balloon. So the beauty with paclitaxel balloon, the protease balloon, is that you can have multiple inflation, 3 inflation you can do with same balloon. So we give multiple applications, and then you can see the result, very well expanded lesion, and there is no recoil, no thrombus, no dissection. This is another case, 35 years old, who had a LED stent 3 months back for anterior wall MI, but he had also this thing, RCA bifurcation lesion, and he didn't want any more stents. So we decided, I gave him an option of doing it with 2 DCBs. He agreed to that. So we did this bifurcation RCA lesion, preparing the vessel with NC balloons, then cutting balloons, and then lesion modification with cutting balloon. Then 2 DCBs were uh, applied here, kissing balloons 2.5, 15, 2.25, 20, and this is the final result. So PLV appears good. There is some recoil in PDA, but we accepted that because there was no STT changes, no problems, no symptoms. So the results were very good. This is another application of DCBs which is being thought of. LED diffuse calcific lesions, tortuous vessel. So we thought of not giving smaller stents to distal or mid-size LED after mid-LED. So we decided to go with hybrid PCI. We prepared the lesion with cutting balloons and then did an IVUS, then assessed the size of the vessel. Then we applied Magic Touch 2.5, 35 from mid to distal LED and deployed a stent in the proximal LED. Then you can see the final result, and this is the this was the final result. So that is how basically we can use DCB in our practice, especially in de novo lesions, when you have challenging anatomies and challenging lesions. So the take-home message is that the idea of leave nothing behind is actually is a great idea. And as per initial 2 talks, the class 1 indication is basically for ISR, and it is 2A for de novo lesions, especially young patients with high bleeding risk, distal small size vessel, bifurcation, diffuse disease. But time will tell, and the experience will tell actually what could be the long-term follow-ups, long-term results, and which balloon to use, sirolimus or paclitaxel or some other drug. Thanks a lot. Thank you.